start today's call with a situation report from Minnesota Commissioner of Health Jan Malcolm and MDH Infectious Disease Director KRIS EHRESMANN. After that, we'll open it up for questions from reporters on the line. I'll also mention that we have Minnesota Department of Education Deputy Commissioner Heather Mueller and Children's Cabinet Assistant Commissioner ERIN Bailey on the call today to help with questions as they arise. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. Around the world as of this morning, we are now over 25.7 million cases and over 857,000 total deaths from COVID-19. The United States is now over 6 million cases and 184,000 deaths. Here in Minnesota, we have a new total of 77,085 cases in our state. This is up 761 laboratory confirmed cases from yesterday. That is on a very large total testing volume that we're reporting today of 27,487 tests. And I want to state right at the outset that very large number includes a large backlog of tests that have just come through the system, and I'll explain further in a few minutes. But the backlog included 16,865 tests from prior times, which I'll again explain. And in that backlogged bunch of test results were 267 positive cases. So without that big backlog that we're reporting today, we would have seen 419 positive cases on a testing volume of 10,829 if there were no backlog. But the correct numbers to report for today are 761 new cases on a total volume of 27,487. We had an additional 7 fatalities reported yesterday that came in to us yesterday that we're reporting today. 6 of these deaths occurred among residents of long-term care facilities. 2 in Hennepin County, 1 each in Dakota, Kanabec, Martin, Ramsey, and St. Louis counties. This total includes 5 persons in their 80s and 2 in their 60s. There are currently 297 patients in the hospital, 135 of those in intensive care. Just a little further explanation on the testing backlog. Again, 16,865 backlogged tests came through and are being reported today. The majority of those were the remaining tests from Valley Medical. And you might recall that we had a large group of backlog tests that that came through on August 26th as well, that were reported on the 27th. So this additional amount of tests is the remaining backlogged tests from Valley Medical, plus an additional number of backlog tests from various other multiple laboratories due to regular processes for getting new labs onboarded with our system. So a couple of things going on there that produced this very large backlog number. I'm sure that was a little confusing, so we can certainly reiterate that during questions if you would like. But the backlogged tests and the backlog positive cases do go back a ways, some of them all the way back into March. So they're being all reported today, and everything reported today and in the next couple of days predates August 10th and goes back over many months. The 7-day average test positivity rate is now at 5.2%. We've seen that number hovering just below and just above 5% for a couple of weeks now, but the 5.2% is up over the week prior, which was 4.9%. And that test positivity rate, as you recall, is reported through August 23rd. So which is our data lag period. So the backlog of tests I just described is not part of that testing positivity rate calculation. That will come through in future days. The 7-day average growth rate in testing is 8.7% from today versus last week at this time, whereas the 7-day average growth rate in new cases is now 8.3%. and this does include the backlog that I just reported. With that, I'll turn it over to KRIS EHRESMANN for some additional situational updates on specific transmission concerns.
Thank you, Commissioner. I'd just like to give an update on community transmission. We are now up to 50 cases associated with Sturgis, and sadly that includes one death among today's total. The death occurred in an individual in their 60s with underlying health conditions who had been hospitalized. We are also aware of situations of secondary spread from individuals who attended the Sturgis event and developed COVID. However, none of these are included in the 50 cases. So the 50 cases are just individuals who reported that they attended Sturgis, not secondary transmission. These incidents underscore the importance of people following the guidance we all heard from White House COVID advisor Dr. Birx when she visited this weekend. She spoke of the 3 pillars of COVID prevention being social distancing, wearing a mask, and avoiding large crowds. We need people to do all 3 as protective layers, not just one. And then I do want to comment on an internet rumor that we'd like to debunk. As a reminder, it's important to be wary of rumors you hear from unsubstantiated sources on social media. Lately, we've been hearing about online rumors circulating to the effect that children who test positive for COVID have been taken from their family members by Child Protective Services. It's hard to believe we're at a point where such nonsense needs to be addressed, but let me state clearly that this rumor is false. I know for many Minnesotans it seems odd that anyone would find such a rumor even remotely plausible, but this is a good reminder that we all need to take a step back, take a deep breath, and reflect on where we find ourselves right now with online misinformation. Misinformation sometimes starts innocently as a legitimate message that gets misunderstood and garbled as it circulates online. Other times, the misinformation may be intentionally sent around for one reason or another. The bottom line is that we all need to exercise caution and not rely solely on social media or unverified, unfamiliar websites for our news. We are doing our very best to be transparent and share information about what is happening with COVID and how we're responding. This information is routinely shared on these calls and online. Minnesota is also home to many highly professional media outlets doing a really impressive job covering this pandemic. Some people may prefer one outlet over another, but whatever your preference, please know that misinformation is a real thing and we all need to carefully consider which sources we rely on for accurate information. And with that, I'll turn it back to the Commissioner.
Thank you, KRIS. Well, as you know, testing continues to be a critical component to our COVID strategy. And this week, thousands of staff who are employed by Minnesota's schools and licensed child care programs will be getting their specific instructions on how to get the free COVID-19 saliva test that we talked about a couple of weeks ago. This delivers on a commitment from the governor and lieutenant governor to provide access to COVID-19 testing for Minnesotans working in child care and pre-kindergarten to grade 12 schools. It's also a specific part of the Safe Learning Plan for the 2021 school year. While these employees can still access testing from their primary care provider or through community testing events, which we will be doing more of in the weeks and months to come, we wanted to also provide access more immediately, if needed, for everyone providing care and education to our children and youth. As we discussed last week, adding saliva testing to our testing system in Minnesota both grows and diversifies our total testing capacity. We hope that this test will provide a convenient, reliable, and quick option for our teachers, school staff, and child care center employees. Earlier this week, the Minnesota Department of Education and the Department of Human Services started the process of emailing out thousands of unique codes that can be used by these educators and staff to request a saliva test. Schools will distribute these codes to all staff currently employed by Minnesota's school districts, charter schools, tribal schools, and non-public schools, and to all staff currently working in licensed child care settings and certified centers. Now, it's very important to note that teachers and staff are not required to take a COVID test before coming back to the classroom or to continue working in a child care setting. Child care has remained open throughout this public health crisis and have provided just exceptional service and exceptional care for our kids. We've seen these providers provide the nurturing and safe care our children need while families are working, and just hats off to them. So again, while it's not required to take a COVID test, we urge teachers and staff to use this saliva test when you need it. Maybe you're feeling symptomatic. Maybe you were exposed to someone who tested positive for COVID. You can use that one test to which you're entitled anytime between now and the end of the year. Again, I just really want to end with a great thanks and word of praise to our education and child care professionals. They've done just amazing work over the past few months to prioritize the health and safety of Minnesota's children, to do incredibly important and difficult planning to try to respond to the pandemic as it evolves. And just want to thank them again and salute their passion and commitment to our students and children. It's inspiring to all of us, and we all are very grateful for the work they're doing. With that, Mike, I'll turn it back to you for questions.
Thank you, Commissioner. Operator, we are ready to take questions.
Thank you. And again, ladies and gentlemen, if you wish to ask a question at this time, please press star then one on your touch-tone telephone. If your question has been answered or you wish to remove yourself from the queue, please press the pound key. Our first question comes from the line of Jeremy Olson with the Star Tribune. Please go ahead. Your line is open.
Thank you. There was a national report today about the White House or the federal government pushing states to amp up their vaccine delivery capabilities to be ready by November 1st. I was wondering if you could comment on if Minnesota received that urgent request and what it has done, if anything, in response.
I'll turn that one to KRIS.
Thank you, Commissioner. Yeah, we have been made aware of that request, Jeremy, and as you know, our team has been actually working to prepare for vaccination really all summer, and we just last week had our virtual visit with CDC about vaccination. So while that information was new and helpful to us, it really hasn't changed the ongoing work that the team has been doing. So we're going to continue to build on the relationships that we're working to establish and the planning that has started, and we'll continue to move that forward, knowing that there may be a need to start vaccinating this fall.
Gotcha. And I guess I just had a bit of a step back question at the moment. I mean, we're reaching a point where there's a lot of positive news about declining hospitalizations and improving outcomes, and certainly a study today saying steroids are working awfully well. I just wanted to take a step back question to you, maybe perhaps Commissioner. I mean, everything we've done so far was to protect our healthcare providers, keep them healthy and keep them with enough capacity to care for people. Are we at the point now where we need to kind of look back and say, okay, we've achieved that goal? Is all of this stuff necessary? I'm just wondering, you know, or is there a new goal? I just wondered if you could comment on that a little bit.
Yeah, thank you, Jeremy. Yes, I think when we first began this journey, one of the very first things the governor said was we need to buy time to figure out both what's going on. This is a brand new virus. We know very little about how it's spread, what's going on, what the trajectory might be, and we need time to build up our healthcare capacity. So it was certainly, protecting workers by making sure that they had personal protective equipment became a real challenge and a real priority, which we dug into by developing a brand new state procurement system and a state cache of personal protective equipment to help augment what the health systems could do on their own and the long-term care providers. But it was also about building time for the healthcare systems to do surge planning, to figure out how they would create more particularly intensive care capacity to deal with a potential large number of cases. And indeed, we did see a large number of cases in the hospital in the late spring. We do feel very good about the progress that's been made on building up surge capacity, on creating an unprecedented level of data exchange and collaboration among the health systems and between the health systems and the state, so that we know what's going on with hospitalizations and can support movement of patients and resources around the system as needed. So we indeed do feel like we're in just a completely different spot than we were in the early spring in terms of our ability to manage. You mentioned the improvements in care that have been seen. Those are really good news, as you pointed out. But we are very worried about the high level of cases, again, because we've learned so much more about this virus. We are now learning about potential and real complications of COVID disease that so far we don't know how long these effects may last. This has only been with us for a few months, but we are seeing very concerning, severe health consequences among people who've had COVID, even potentially milder cases of COVID who come down with significant complications later on. So we are focused on trying to reduce the number of cases in order to prevent long-term health damage, in addition to hospitalizations and mortality. We're grateful, as KRIS often says, every day that we see stable or declining hospitalizations and certainly mortality. But there is this broader picture of long-term health damage from COVID, as well as the enormous disruptions that high numbers of cases cause, for instance, to schools being able to do in-person learning or to execute the learning plans and the models that they've worked so hard to prepare. Highly disruptive to employers when large segments of the workforce are out due to illness. So I know I realize I'm giving you kind of a long-winded answer here, but it's a great question, and I think it just speaks to the need to keep asking that question. What are our goals? How are we doing against those goals? And as we learn more about the pandemic, do we need to add some new goals? And certainly supporting the importance of as much in-person learning as we can has become a goal that we've been really focused on in recent weeks. Another really important goal is holding on to the gains that we've made in improving and reducing the rate of illness in long-term care and other congregate care settings. That is at risk with these high degree of cases. So it's become, I think, a much more nuanced picture with some additional goals beyond just let's make sure we've got enough healthcare capacity to deal with the really severe cases. Thank you for the question.
Thank you.
Thank you. And our next question from the line of Matt Epic with Minnesota Public Radio News. Your line is open. Please go ahead.
Hi there. This question is for either of you. I'm curious, where will the saliva test be processed? Is that going to be happening here in Minnesota? And is there the capacity to handle them, given the backlogs that we've seen with the other tests?
Yeah, this current round of saliva testing, and again, Deputy Commissioner Heather Mueller and Assistant Commissioner in leading our Children's Cabinet, ERIN Bailey, are both on the phone, and I would invite either of you to comment on this if you know more of the details than I do. But my understanding is this first round of saliva testing will be processed in the New Jersey lab, as the Minnesota lab is going to take some weeks yet to get up and running. And we don't have any concerns about backlogs in turnaround time with that lab.
And how many tests are available now, and how many are expected to be needed, particularly with the start of the school year around the corner?
Heather, I don't know if you have, Heather or Erin, I don't know if you have those data at your fingertips.
Yes, well, I appreciate that, and I can give an answer for our K-12 system. So the way that we looked at getting those URL numbers is we looked at any employee with a W-2 in a public school, a non-public school, and a tribal school. All are receiving URL codes for the at-home saliva test. Contracted employees would not be eligible for this test, but they can access tests at other locations, and those are listed on our on Department of Health's website. And so we really were able to get that information to identify who our W-2 staff were in the staff automated reporting system, as well as the statewide W-2 employment data to determine staff count.
And about how many people is that, would you say?
Roughly 250,000 in total.
Okay, and this is Heather, correct?
This is.
Okay, thank you.
Thank you.
And this is Erin. I would just add on that to the lab question that you're exactly right. As the saliva testing lab in Minnesota comes online, we'll be reevaluating how this moves forward. But these testing codes are available through the end of this year.
And I guess just one more follow-up with this. Are school staff being encouraged to take these tests regularly, or is this something that you're asking them to do just when they begin the school year?
This is Heather, and actually neither of those are accurate. That what we are giving them is this test is for if they feel as though they are ill, or if they believe that they have come in contact with someone and they are not able to get into their local provider. Every staff member that was identified here has one test that's available to them. They do not need to be able to take this test to come back to work. They do not need to take this test. They do not have multiple tests that are available to them. It is one singular test, and so that's how they've been identified.
Okay, thank you.
Mm-hmm.
Thank you. And our next question comes from the line of Tim Bolts with Fox 9. Your line open, please go ahead.
Well, hello. Thanks for taking my question, Commissioner and KRIS, and whoever wants to take a bat at it. Commissioner, you may have seen some new research coming out from the Journal of the American Medical Association last night that shows an association between statewide school closures and a reduction in the incidence of COVID-19 and mortality. And when they put Minnesota in the quartile of states, in the second highest quartile, when they looked at the data between March 9th and May 7th, Minnesota had an adjusted 55% reduction in COVID incidence of COVID-19 and a 54% reduction in deaths from COVID-19. Two questions here. Number one, does this kind of correlate with data that you have seen at MDH? And question number two, does this perhaps inform the state on should we get another big wave about the efficacy of closing down the schools statewide again?
Well, this is Jan, and I have not seen that JAMA study. It's very interesting. I don't know if KRIS or Heather or Erin perhaps have had a chance to review that study, but KRIS, could you take the first crack at I don't know if you've read it, but
yep,
the question of how it compares.
Sure. I mean, I think that, you know, what it tells us is that there is a value, and when we shut down our society, that makes a difference in reducing disease transmission, both when we're doing it related to schools and when we're doing it related to other, you know, societal activities. I think that one thing to keep in mind is that we recognize the value of schools, and certainly I would turn to our educators to speak more eloquently on the important role that education and schools play in our society and for our children. But, you know, obviously our goal in the last months has been to identify how we can maximize educational opportunities in the safest manner. And certainly I think that if we start to see unbridled transmission and real concerns, we know that closing things down can have, you know, a positive impact on that. But as with all the decisions that need to be weighed, that has to be looked at both from a public health standpoint as well as from a societal standpoint. So this is useful information, and it's always good to have scientific documentation of kind of what is intuitive. But I think that we're at a point where we're balancing, you know, benefits and risks at this point. But I'll certainly defer to my educator colleagues.
Well, thank you, Chris, and this is Heather Mueller. I think that to the point of that is when that decision was made in the spring to close schools for in-building schools statewide, it was a very difficult decision, and the things that were first and foremost is the health, the safety, and the wellness of our students, our staff, and our families. And so that has been at the center of all of the decisions that have been made since. And so in the development of our safe learning plan, that again was the foundational piece. And then built upon that for the next level up was we really want our students in school. If we can maintain the safety and the health and the wellness for our students, staff, and families, then our next piece of that would be really the building blocks of making sure that we can have students back in school, because we know the role that in-person learning plays for our students. We know the other services that are provided in addition to academics, the social emotional learning, the mental health support, the nutrition, the physical activity, the interaction and socialization with other adults who care about them as well as with their peers are all incredibly important pieces. And all the while, we are also thoughtful about recognizing that there were some students who did do better in a distance learning model. And so with that being the center, I think that to Chris's point that she mentioned is it's going to be a consistent evaluation of if there are risks, what are those risks, and do they outweigh the benefits that we get from education, and how do we continue to monitor and adjust based up on those pieces. But I think that with that center always being about our students and staff and our families and thinking about their health and their safety and wellness, it really gives us an opportunity then to build from there.
Thank you so much. I deeply appreciate your thoughts.
Thank you. And our next question is from the line of John Lawrence with WCCO-TV. Your line is open. Please go ahead.
Hello, everyone. Thanks for having me. Quick question. One of the COVID models the White House uses is from Institute for Health Metrics and Evaluation. It's got some interesting predictions as far as predicting that Minnesota fatalities could rise to about 10 a day next month, potentially 50 a day by the end of October, and even going up from there. But it does also address the universal mask wearing would virtually cut those numbers in half. My question for you guys is, are you following the same model the White House is using, Institute for Health Metrics and Evaluation? And does that caveat that says mask wearing would cut these fatalities in half give you kind of some ammunition for people that say masks just aren't important?
Well, thanks for that, John. And the quick answer is yes. We follow closely a whole bunch of models, and the Centers for Disease Control and Prevention actually does a real service by kind of tracking about 30-some models and kind of coming up with an aggregation of what they show. And certainly the IHME model has been referenced a number of times by a number of folks. And it's always important to say, and we say it all the time, that all of these models show a very wide range of potential outcomes. The one that tends to get publicized is sort of the most expected scenario, but it's just important to know. So to note that even the IHME model, has a fairly wide range around it. But yes, I think that any evidence that we can come up with, and models are not necessarily evidence; they're intended to be to help identify what could happen under a range of scenarios. And I think one of the things models are useful for is pointing out the potential difference from at least a mathematical modeling standpoint of the impact of different policy interventions. So the value of universal masking, we think, has been well demonstrated through a number of studies, and we appreciate the IHME model's quantification of that too. So and we appreciate all of your help in trying to publicize the evidence as it comes in on the importance of mask wearing. It's certainly part of what we continue to reinforce is the importance of mask wearing. But I just also want to reinforce something Dr. Birx said last weekend, and Chris reiterated again, that masks by themselves are not a panacea. It's masks
as well as paying attention to avoiding large crowded gatherings and close contacts. Wearing a mask is not a recipe for saying it's fine to, you know, to avoid and to ignore all of that other guidance. And certainly, if you're sick, wearing a mask is not protective of the people that you're interacting with to that degree. So it's certainly important, but and again, I think as Chris said and Dr. Burke said, it's about the layering of all of those protective things that really starts to show the dramatic impact. And I'm not familiar enough with IHME's methodology to know the extent to which they factor in those other pillars of social distancing and crowded spaces as well as masking.
Okay, thank you.
Thank you. And our next question comes from the line of Paul Scott with Forum News Service. Your line is open. Please go ahead.
Hi, thank you. I'm wondering if you can tell us anything more about the individual who died after attending Sturgis, whether you could say anything about what kind of activities they took part in, whether they were in large crowds, indoors, masked, that sort of thing.
The cases that we have interviewed who attended Sturgis have indicated that they attended multiple events, stayed at multiple campgrounds, were inside, outside, and I think given the number of individuals that were participating in the Sturgis event, I think it's fair to say that pretty much everyone was in a crowded setting. So don't have any specific activities that individual participated in any more than just participated at Sturgis in multiple different activities. And okay. Just if I could add something, recently I have gotten a lot of questions about indoor and outdoor activities, and I want to be clear that while we have very much said that being outside is preferable to being inside, all things considered, when it comes to COVID transmission, being outside does not eliminate risk. And being outside, if you're not socially distanced, if you're not wearing a mask, if you're not being attentive to all the other important mitigation measures, washing your hands, all of that, it doesn't save you, if you will, from COVID. You need to, if you're outside and you're doing the recommended mitigation activities, those three pillars, then you have added positive benefit because you've got more space, you've got good airflow, and you've got sunlight. But in the absence of that, being outdoors is not sufficient in and of itself to eliminate risk from COVID transmission. So I just want to clarify that, since there have been a lot of questions recently, it seems, kind of wanting to differentiate between indoors and outdoors. So I think that's an important piece to clarify.
Thanks. I got one follow-up. It's a little unrelated. I'm just wondering if you've tracked any COVID-19 cases from any Minnesota campaign events. I guess apparently today DFL leaders called out GOP for holding events in person where folks were seen without masks or distancing.
We certainly, when we interview the cases, we do ask them about their activities. And we learn what they have to tell us. If they don't tell us about an activity, we won't know about it. And at this point, that has not been something that's been flagged for us as a potential source of exposure. That's not to say that it couldn't in the future, or that it hasn't happened, but not something that has been brought to our attention at this point.
Thanks so much.
Operator, we have time for one more question.
All right. Our last question comes from the line of Joe Cox with Minnesota News Network. Your line is open. Please go ahead.
Returning quickly to the question of goals that was brought up earlier, the focus on case numbers as well as comments on concerns over the lingering effects of those who have had COVID would seem to indicate a goal of eliminating cases altogether. Maybe that's stating the obvious, and while that seems like a noble goal, certainly, is that something that's an achievable goal, like increasing hospital capacity and things like that, that warrants continued restrictions and disruptions and the potential negative impacts that those could have on society?
Thank you for that. It's a good clarifying question. I think we've said since the beginning, and we certainly still believe, it is not possible to eliminate cases, particularly not at the state level. And I don't think any of us are expecting to drive cases to zero. What we're trying to do is keep the rate of case growth manageable and frankly, to keep transmission as low as possible, both for the health effects, but also for the disruptive effects that high levels of transmission have, as we've been talking about, on employers, on schools, on our ability to kind of open up society for all the positive benefits that brings. We definitely are, kind of focusing on the importance of keeping case growth in a manageable zone, in no small part, so that we can keep these activities open. But it also really helps us to be able to then more quickly respond when there are outbreaks, where there are hot spots, then we can find those and note and be able to intervene more quickly and keep it from spreading further. When case growth and community spread is this high, it's very hard to find those outbreaks in the overall kind of the noise of all the underlying activity, if you will, that's going on. So when you look at states that are having good success, like what New York State has achieved, really stunning success after a hellish experience that they had earlier this spring in driving overall case growth to a low enough point that they really are able now to jump on, to see and jump on hotspots quickly as they emerge, and that is our goal.
All right, thank you.
That is all the time we have for today's call. If you have a question we were not able to get to, please feel free to reach out to the communications office this afternoon. Have a good day, and we will be back with you again on Friday.
This has been a WDIO News Special Report.